So what is heparin-induced thrombocytopenia? As the name suggests, it's the decrease in the concentration of platelets on exposure of the heparin. Its incidence is 5 to 28%. It is not uncommon to have heparin-induced thrombocytopenia in patients. How do we diagnose it? So, suppose you have a patient and you start heparin on it, and you are monitoring the platelet count. If the platelet count decreases to less than 30 to 50% of the baseline, or at the start of the heparin, it is one of the diagnostic signs of heparin-induced thrombocytopenia. Or if the platelet count decreases to less than 150,000 per cubic milliliters, that is another sign that the patient may have HIT or heparin-induced thrombocytopenia, and you should think about it and you should send test for it. It is basically two types, type 1 and type 2. The type 1 is the benign type. It occurs within 2 to 5 days. It is mild. It is self-limiting. And the drop in platelet count is not massive. It's a small decrease in the platelet count. And it does not respond. It does not require any treatment, and it does not involve any immune response. And it does not cause any thrombosis. It's the type 2, which is more important and which is more fearful. It is severe. It occurs mostly after 5 days of heparin administration. It is immune-mediated. It occurs because the antibodies develop against that complex, which we just discussed, between heparin and platelet factor 4. And those antibodies combine with this complex and causes thrombosis, causes the clumping of platelets and causing clots inside the blood vessels. Not only that, but it also causes endothelial injuries and complement activation. So if we see in this slide, in panel A, it shows alpha granules in the platelets. The alpha granules are the granules which contains platelet factor 4. On exposure of heparin, the platelets are activated and release these platelet factor 4s, which then combine on the surface of platelets. And along with heparin, which is present in the blood, they form heparin platelet factor 4 complexes. And these complexes started developing antibodies against it. And these antibodies, platelets have receptors for these antibodies. So when these antibodies are formed and combined with platelet factor 4 and heparin complexes, there are big clumps of platelets formed, and they release further procoagulant microtubules from the platelets, and the whole coagulation system activates. So there are certain tests available which we can send to confirm the diagnosis of HIT. And the most important of those are 3 tests. Heparin-induced serotonin release assay is the gold standard test. It has very high sensitivity and specificity, but the problem with this test is it's a complex test. And it is available only in the regional big laboratories. Even in the United States, not all hospitals and the laboratories have kits for these tests. But it's a gold standard test for the diagnosis of HIT. The other 2 tests are very commonly done in all the laboratories. The second test is heparin-induced platelet activation assay, in which the patient's serum is combined with the donor platelets, and they put heparin in it and see the aggregation of the platelets. And this test is not very sensitive, but is highly specific for HIT. The third test is very commonly done. It's the detection of anti-heparin TF4 antibodies. And the technique used for this is enzyme-linked immunosorbent assay. rarely of HIV. There are a lot of techniques described in literature. One of that is plasmapheresis. Via the plasmapheresis, we can try to decrease the load of antibodies present in the serum, antibodies against the platelet factor 4 and heparin complex. This type of treatment is not very popular. The second type of management of the patient with heparin is using any antiplatelet medication. And we have two medications like that, which is prostacyclin, also known as apoprostenol, or Flolan, the market name is, and dipridamole. The thinking behind it, the philosophy is, by using these antiplatelet medications, even if the patient is currently having HIT, and we give heparin to the patients, the HIT type 2, it forms clots because of the activated platelets, and it's the platelet activation which causes the whole problem. So if we give will not occur. And this kind of technique is useful and is being used in patients with HIT type 2 going for cardiopulmonary bypass and PCI, which is the percutaneous pulmonary intervention. The problem with this type of technique is, as all of us know, the platelets play a pivotal role in coagulation. So at the termination of bypass, the patient do bleed a lot and require a lot of factors and a lot of extra work on the part of cardiac anesthesiologists. But it's a very well known and very well practiced technique for HIT type 2 patients going for cardiopulmonary bypass. The third type of technique we can use for HIT patient is not to use heparin, but to use direct thrombin inhibitors. The examples are hirudin, bivalirudin, and argatroban. We will discuss about direct thrombin inhibitors in a little more detail in the later slides. Another strategy which can be used for patients with HIT type 2 and have to go on bypass is, if it is not an emergency bypass surgery or any kind of cardiac surgery involving the cardiopulmonary bypass and the exposure of heparin, we can delay the patient the surgery for about like 6 to 8 weeks, and then repeat the tests for the antibodies and see what is the antibody titer in the blood. Normally, after about 2 months to 3 months, the concentration of antibodies are undetectable in HIT type 2 patients. Once they are undetectable, we can go ahead with cardiopulmonary bypass in a normal, usual way using the heparin. Because there are case reports and there are studies done on this type of technique, because the secondary immune response, by the time it will kick in, the heparin will not be available to continue the whole process. Means that in cardiopulmonary bypass, we use heparin for about a couple of hours and then reverse it, and then it has a short half-life and it will be gone from the system. By the time the secondary immune response will develop antibodies, no more heparin is available to form heparin platelet factor 4 complexes and to cause thrombosis. This technique is used for cardiopulmonary bypass but is not recommended for the continuation of heparin infusions. So the patients cannot be placed on a heparin infusion afterwards. It has to be direct thrombin inhibitor infusion or some other thing. So what are the alternatives to heparin for cardiopulmonary bypass? Let's say, can we use low molecular weight heparin? Of course, it has the last polysaccharides of heparin molecule, but its half-life is at least twice to that of heparin. So you have to wait for it to just metabolize and clear from the system. And all of us know that it needs kidneys, good renal functions to be secreted from the body. We can use protamine to reverse it, but the problem with that is it only reverses factor 2A inhibitory activity of the low molecular weight heparin, not the predominant 10A inhibition. So by using protamine, we are reversing only a small part of anticoagulation activity of lower molecular heparin, not the big major part. So the patient will bleed and will cause problems. The most important point is we do not have a reliable, readily available, a bedside test to measure lower molecular weight heparin anticoagulant activity, because the ACT and activated partial thromboplastin enzymes, they are less sensitive to factor 10A inhibition. We can send a factor 10A level to the laboratory, but it takes a lot of time for the result to come back in. So lower molecular weight heparin, we cannot use it for as a replacement of heparin for bypass. Another class of drug which has been used in a couple of studies and case reports are called heparinoids. Two medications in that, dermatan sulfate and danaproid. Danaproid is sometimes some of the people who are very much familiar with this drug, they use here in the United States, only if they cannot use heparin, of course. This class of drug is glycosaminoglycans, and it has heparin-like properties. The problem is, again, the same. The patients bleed a lot, so they are less desirable for cardiopulmonary bypass. The next class of drug is direct hormone inhibitors. The classic drug is hirudin. The hirudin is formed from the salivary glands of the leech, which is called hirudomedicinalis. Does not require antithrombin 3 and does inhibit thrombin even if it is bind to the clot. It is secreted by the kidneys. It is easily filtered at the end of the cardiopulmonary bypass. So it's one of the good choices if we need to use anything else other than heparin. Argatroban is another direct hormone inhibitor, but here in the United States, it's not approved by the FDA for cardiopulmonary bypass. But it is being used and approved for the cath lab purpose, like for angioplasties, stent placements, and in the vascular surgeries for carotids and for other things, but not for cardiopulmonary bypass. Ancrod is another class of drug for anticoagulation. It is derived from the Malayan pit viper venom from the snake. It lyses fibrinogen. It has extremely long half-life of 3 to 5 hours. So if you have a short bypass run, there is no way we can, because we don't have any antidote for it. So keeping all these things in view is not recommended for cardiopulmonary bypass. So by far, direct hormone inhibitor is an appropriate choice for heparin if we have to take the patient to the operating room with HIT type 2 and for the cardiopulmonary bypass anticoagulation management.